Okay. Well, hello everybody. Welcome to the Healthy Joints, Healthy Lifestyle Show. My name is Arinola Dada. For those who don't know me, I help people with joint pain become pain-free and people with autoimmune diseases get their immune system back on track. So I am a rheumatologist. And today I have an exciting talk for you because I have the Dr. Dana Gibbs. She is an otolaryngologist as well as an allergist as well as so many other things that she's going to tell us about. But she's a thyroid and hormone expert, and that's really where most of our focus is going to be today. So, all you ladies, you've been told that you have this thyroid antibody. She's going to tell us what that means and why we're all gaining weight. Okay, in the meantime, so Dr. Dina Gibbs, we were talking about how long ago she graduated from med school. I'm going to let her say that because she doesn't look it one bit. But she attended med school in San Antonio, Texas, and was trained in otolaryngology at the University of Kansas. I'm so glad to have you here, Dr. Gibbs. Please bring us up to speed. It's been a long time since you left Kansas.
Yeah, no, it has been a long time. So, yeah, I'm Dana Gibbs. I am a retired now otolaryngologist, and I started a whole new practice doing something that really interests me personally, which is hormone and thyroid management. I graduated from med school. We were just talking 30 years ago. Oh my goodness, I can't even believe that. Um, but part of otolaryngology is, of course, taking care of patients who have thyroid cancer, thyroid nodules, most of which, believe it or not, turn out to be chronic lymphocytic thyroiditis. And that is another name for Hashimoto's disease. And so I really got interested in Hashimoto's disease back when I was doing surgery because we're taking out all these nodules and it's like, look, you didn't need to have this surgery. If we could have
Yeah,
figured that out on a fine needle biopsy and by checking your antibodies and by
yeah.
watching, we would have known, hey, we didn't need to do this surgery. Um, Another reason I got interested in it is because I was having all the symptoms of low thyroid. And I started that. Oh my gosh, even before I was in med school, I was having those symptoms. I was tired all the time. My hands and feet were always freezing. Everybody else was going, oh, it's so hot. And I'm like, I'm freezing. What are you talking about? Um, and
I'm
I
freezing
wasn't,
all the time too.
well, we can work on that too. Um, but yeah, cold all the time, constipated, tired, dry skin, hair falling out. There's just so many symptoms. And um, and weight gain is a huge one that I personally didn't have. And so when I went to the health clinic in med school and told them all my symptoms, and they checked my TSH and said, your TSH is fine. You don't have anything. Here, take some antidepressants. Well, that was the start of it, but it got worse from there. Um, and because of it, my energy levels were terrible. I had a really hard time getting through residency.
Wow.
Um, and, it was really, it's kind of a backdoor way to get into treating this, but I was my own first patient. And when I found out, hey, you know what? You don't have to have an abnormal TSH to have something serious wrong with your thyroid that can be fixed. It blew my mind. It really did. And so when I found a treatment that helped me, it was miraculous. It was like all of a sudden these energy levels were back to normal. My hands weren't cold anymore. Just so many. My GI tract was okay again. My hair grew back. Oh my gosh, it was so nice. And at the point where I started noticing patients in my practice having these same symptoms. They'd come for a thyroid nodule or they'd come in for, chronic, terrible sinus that won't go away. And
Yeah.
I would say, you know what, you've got some of these other, we do this long laundry list of symptoms. It's system review. We do that every time a new patient comes in. All doctors do that. And I would say, you've got 3 or 4 symptoms that make me worried about your thyroid. Let's check the blood tests. And I would start them on the medicine and then they would disappear for a while. And I'd be like, oh, they didn't like me. Okay, fine. And then 6 months later, they'd be back
That's
and I'd say, hey,
impossible.
hey, when are we gonna do your sinus surgery? And they're like, oh, I don't need that anymore. It's all better. I just want to refill on that thyroid medicine. And I'm like, what? Wow. And so that's actually another big way that having thyroid problems can affect people, which is it really shuts down your immune system's ability to fight inflammation, fight infections.
Yeah, and
And
we
so,
experience that with our patients too, exactly. But you know, you brought up the issue, which I still struggle with how to help my patients, right? If
sure,
they're having
absolutely.
symptoms, I think their thyroid is abnormal in some way. I do the thyroid test, and the TSH and free T4 thyroid tests are normal. And
Mhm.
so and then I shrug. Then it becomes so what to do next? Because I don't even know how, I don't even have enough evidence then to even send them to endocrine, right?
Right,
So
right,
and
right.
most of the time I would say endocrine does the TSH free T4s and say it's not your thyroid, go back to Dr. Dada, right? So that's kind of where we're.
That that is, yeah, that's the vicious cycle that, and people are so frustrated, and then they go out on the internet and they buy all these expensive supplements and do these coaching programs that are from people who aren't even doctors, and it just frustrates me to no end. But here's the thing. So Hashimoto's disease is an autoimmune disease.
Yes.
It is very frequently like the sentinel autoimmune disease that people will get, and end up back in your office later with RA or Sjogren's or psoriasis or celiac or lupus even. um, and so it's something that should not be ignored. And the way that I have come to, so it's an integrative medicine kind of an approach. And a lab test that was originally a research test that I actually use very, very frequently to help people figure out, okay, is your thyroid function
Yes.
normal? Because you can have this condition, and it's called non-thyroidal illness. And
Yes.
non-thyroidal illness is something that most of us only heard about in the context of the ICU, when people are severely septic, or severely injured. And what non-thyroidal illness is a change in how your body processes the T4. The T4, for people who don't know, so you step back just a second. So
Thank you, because
T4,
I was about to. Yes.
yeah, T4 is the primary hormone that your thyroid makes. And
Yes.
it's actually kind of a precursor, because in order to be absorbed into your cells and used by your cells and go to the nucleus and actually do the things that thyroid hormone does, which is, for the most part, it's making proteins that activate your metabolism. It grows your hair. It um, gives you energy. It moves your colon along so that you have warmth. There's a lot of stuff. But anyway, in order for T4 to go into your cells and do all that stuff, another one of the iodine molecules has to be knocked off. Now, so T4 has 4 iodine molecules on it.
Okay.
As it's produced in the thyroid gland. The thyroid gland also makes a little bit of something called T3.
Yes.
And T3 has had one of the iodine molecules knocked off
Okay.
by a specific kind of enzyme called a 5' deiodinase. And it's not important that you remember that.
Okay.
But anyway, if your body senses that you have too much T4,
Yeah.
which is something that happens in Hashimoto's disease, because when your antibodies, or when your cellular immunity is attacking your thyroid, it's spilling T4 out
Yeah.
on random days and at random times, and it'll go really high and then it'll come
Okay.
down, and then it'll go really high again and come down.
Okay.
And your body has a defense mechanism against those high levels of thyroid
Okay.
hormone.
Okay. Of free
And
T4.
that
Okay.
Yeah, and that defense mechanism is a different kind of deiodinase enzyme that knocks off the wrong iodine molecule off of the T4.
Okay.
And so it ends up producing something called reverse T3.
Okay.
And if you put them in a mass spec, they have the exact same molecular structure, except that the iodine that was taken off is the wrong one.
So let me back up a little bit just so that
Yeah.
our audience is clear, right? So the thyroid produces a free T4. A free T4 is our friend. That's what goes to the cells and helps you do all the good stuff that prevents us from moving around like a turtle, right? And then there's also T3. The problem is that if your body makes, really high levels of this free T4, it sounds like what it does, then your body knocks off the wrong iodine. And if it knocks off the wrong iodine, it now becomes this reverse T3. And then Dr. Gibbs about to tell us, so what?
So what? So here's an analogy that may make sense. So if you've ever gone to have a new key made for a lock that you have in your house, and they make it just a teeny bit wrong.
Yeah.
You can put it in, but you can't make it turn. And the lock is, and if you get really mad and you break the darn thing off in the lock, then you're really hosed.
Yeah.
And that's basically what happens with reverse T3. Reverse T3 will fit the receptor molecule on all of your body cells, but it won't do anything. It sits there and blocks the actual T3, the real T3 that wants to do something in the body. So your T4 can be normal, but your T3 can be normal too.
Okay.
But if you have high levels of reverse T3, you'll still feel like you don't have enough thyroid hormone.
Okay.
And
so should we be measuring this then? Should we
always measure.
Measures reverse T3.
I always measure it. Okay. And here's something important that you need to know about reverse T3. So reverse T3 is only present normally at about 1/10 as much as T3.
Okay.
And T3 is 1/10 as much as T4.
Okay.
And when we measure free T3, when we measure free T4, that's only about 100th as much as the total T3, total T4 numbers that we could theoretically order. Okay. Reverse T3, because it's such a tiny, tiny little amount, we can't measure free reverse T3. It's below the detection limit of the blood test.
Oh, okay.
So what we're getting is total reverse T3. Okay. And so when we try to measure reverse T3 against free T3, what we get is a mess, because free T3 is the tiny little amount of T3 that's not bound to all the proteins that it circulates in your system. Okay. And those proteins can vary a lot based on your metabolic status, how much albumin you have, how much sex hormone binding globulin you have. So doing a calculation from reverse T3 to free T3 to try to compare them is a mess. It's a mess.
Wow. So what do we do, right? So if we kind of move away from the molecular state, so basically your doctors measured a free T4, they've measured a T3.
So you can measure total T3.
Total T3, okay.
Right. And you compare that to the total reverse T3. Okay. And then you're getting an apples to apples comparison.
Okay. So the doctor needs to monitor, at least you can ask for a total T3 and a total reverse T3.
That is correct.
Two molecules. Okay.
That's what I do all the time. And that's what almost no doctors that I know of know to do, because they don't know about this problem.
Yeah. Okay. That's helpful for our patients, because there's a lot of frustration out there. My T4 is normal, my free T4 is normal, my T3 is normal, but they need to measure the total T3 and the total reverse T3. Okay,
correct.
So let's move away from the basics of it now, and let's kind of go into kind of what are the warning signs that patients experience, right, with Hashimoto's thyroiditis?
Okay. So first of all, Hashimoto's thyroiditis is something that is 10 times more likely 4 to 10 times more likely in women. And it is very, very frequently diagnosed after a big stressor, like a pregnancy and a delivery, and or some other period of extreme stress in somebody's life. And I'm not exactly sure why it's so much more to do with women. There's got to be some kind of genetic,
Estrogen imbalance, stressor,
estrogen
maybe
imbalance, stressor, something like that triggers it. But research is very lacking in Hashimoto's disease. I have to just say, research is very lacking, and there's so much
as to why people get Hashimoto's disease.
As to why people get it. But the symptoms, when somebody first gets it, can be very, very subtle. Like, for example, I diagnosed a 16-year-old the other day, and her symptom was she was anxious and her throat hurt and she got hoarse. And when I felt her neck, where your thyroid gland is, she was a little bit sore and tender to the touch. And when I touched it, then it kind of, that area on her neck turned kind of bright red. So that's something that a doctor would possibly diagnose.
And so that's the early stage, right?
That is the early stage.
What about when you're well into it?
Okay, so when you're well into it, because so many people don't get diagnosed when they're early stage. Most people who are diagnosed in their 30s, middle years. And the symptoms really overlap an awful lot with a bunch of other stuff. So weight gain is probably the number one people get, that they suspect, oh, I might have a thyroid problem. Or they might have, okay, I'm starting to lose my hair, not on the sides, not male pattern hair loss, but right in the middle of the top of your head.
Top.
Yes. Another thing that I see a lot is that people will start getting very puffy around their eyes. They will start losing the outer edges of their eyebrows. So like,
lots of hair.
Women, they fill that in with makeup, but I always look really close. I'm like, did you put makeup on? Because I can't see that you have any hair there. So that's something that I really, really look at. And then if their thyroid feels lumpy and kind of irregular, not necessarily sore, but just kind of rubbery and firm and maybe even with a nodule in it, then that's kind of the first thing I diagnose, or I look for, because, people with thyroid nodules, it's possible that it's cancer, but I would say 95% of the time it's a Hashimoto's thyroid nodule that they have.
Do you find that that's really helpful, I think, for people, but do you find that people also kind of get sluggish, sad, and depressed? Do you feel are there emotional manifestations of it?
Yes, I do. And the problem with that is that those symptoms can be caused by so many things that most people who have them are not, unless they're on the Google searching and looking for their symptoms, it doesn't occur to them it could be their thyroid.
That's true. And in my world, they can present sometimes with joint pain, right? And muscle pain.
Yes.
With a lot of times we kind of see that, and that's kind of what triggers why we have this relationship with the thyroid specialist.
Yeah. And the problem is that menopausal hormone loss can also present with
you can look just like it.
It can look just like it. And what I see is a lot of times that somebody who heads into perimenopause will come to me and they'll say they have these symptoms. And I'm like, yeah, okay, it could just be menopause, but let's check your thyroid too. And sure enough, a lot of times I'll find that. So the symptom pattern is broad and vague, and it overlaps so much with
Yeah.
other things that, you know, we doctors talk about the index of suspicion. Well, I mean, you really kind of have to have this index of suspicion.
Yeah, that you're so right with that. So so I think we've kind of talked through kind of, you know, how they present, you know, having a high index of suspicion is more common in women, and it's the same women that are going through menopause when they get to menopausal ages. So what are the treatment options? We kind of talked about the pain. Tell me that there's hope out there, because, you know, the thyroid function, as far as my doctor is concerned, TSH is fine, PT4 is fine, go home, stop bothering me. What are the options for people?
Okay. All right. So first of all, you know, if you have not found a doctor who's willing to do the blood test that I mentioned, there are a few things that you can do on your own to make things better for yourself. And I would say the number one thing is diet. Because a pro-inflammatory diet will increase the activation of the Hashimoto's disease. And like you were mentioning, sometimes it's middle age or later, it's very late stage, these people get diagnosed. And they may be that it may be that their thyroid can recover and still be fine if they get away from the inflammation. And so the kind of stuff that I recommend that people start with tends to be a low inflammatory diet. So avoiding commercial dairy products, avoiding gluten, avoiding just a lot of carbs in general. You know,
things that come in a box, I recommend. Things with the preservatives, all the things that are going to trigger your immune system.
Toxins, preservatives, plastic,
pesticides.
Products, beauty products that have hormone disruptors in them. Oh my gosh.
Interesting.
So there's so many things there. But the other thing is I really encourage people to keep looking for a doctor who knows how to prescribe T3 and knows what reverse T3 is. Because we're not super common, but we're out there.
Okay. Well, so I'm going to ask you, I think, I'd like to know, you know, could you share a story about a patient who had like an amazing outcome after being under your care? Because I think it really helps us to identify ourselves in some of the stories.
Sure, absolutely I will. So I have a patient. She was in her mid-30s. She was not overweight. She was a psychiatric nurse practitioner. She's a psychiatric nurse practitioner. So she's very educated about health type things. And she came to me, actually, it's a kind of a crazy thing because I saw her when I was in ENT still. And she came to me because she was having allergy symptoms, because that's another common crossover, like, you know, the sinus, the allergy, the immune system problems. But, you know, when I did her system review, she had several symptoms that were suggestive, but she was also trying very, very hard to have a baby. And she was not able to. She'd had a couple of early miscarriages, and she was having a very, very hard time getting pregnant. Her periods were terribly irregular. And this is common. This is another common thing. So if a younger woman, somebody who is not menopausal, has those irregular periods and the infertility, then one of the things that I really strongly feel like this thyroid issue ought to be checked. But anyway, you know, I read her review systems and I said, hey, I think you have a few of these, and I hear your distress over not being able to have a baby, and I think maybe I can help you. And so we did her labs, and I started her on, you know, a little bit of a change in her diet. She was already eating very, very healthy. She was doing everything right.
Oh, she was a nurse practitioner, already pre-educated, right? So at least you were not starting from a negative position.
Correct. She was really already doing everything possible correctly. But when but when we checked her reverse T3 and total T3, her ratio of reverse T3 to total T3 was about 2.5. And that's horrible.
What
Because
ratio should we expect, right? So
you
even
should expect 10 or greater. Total
okay.
T3 divided by reverse T3 should be 10 or greater.
Total T3 divided by reverse T3 should be 10 or greater. Okay.
Yes. Yeah. So when I got her labs back and her ratio, and her absolute levels of free T3 and free T4, they were okay. Not great, but they were okay. Her TSH was not high. Like I said, she was a thin little lady.
Yeah.
She was not, somebody you would look at and go, oh yeah, you have terrible thyroid problems. So I started her on a very slow and careful addition of T3, which is what you do for these patients. And I monitored her very closely. And, it took a little while. It probably took about a year for things to kind of get back to normal, for her reverse T3 to start coming down. And she was able to get pregnant. And it was kind of a disruptive, sad thing, because the first time she got pregnant, she went to her GYN and her GYN said, oh, you can't be on that T3, it's dangerous, and took her off of it. And she lost the baby.
Wow, that's unfortunate.
And she came back and we tried again. And this time she went to her GYN and she said, I'm doing it my way this time. And so we checked her labs every 6 weeks, and we kept everything very tightly within the normal ranges, but we kept her reverse T3 low. And she was able to carry that baby to term. She delivered vaginally. She didn't have to have infertility treatments. And now she has 2 babies, and it's so exciting.
Wow, that's amazing. So interesting.
So exciting for her.
So that was my next question is, so your doctors put you on some T3, and then that needs to be monitored. So you can't just take the pills and disappear, right? You need to kind of with your doctor and monitor to kind of make sure that it's adequate, it's not over, it's not more than you need, and make sure that that is being monitored. Right.
No, you can really harm yourself by taking high levels of T3. You can really harm yourself by okay, I got to back up for a second. So there is a natural product called Armor Thyroid, or natural desiccated thyroid. A lot of patients come in asking for it. They come in and request it. And the problem with natural desiccated thyroid is that it has T3 in it, yes, but it also has T4 in it. And for some, and it's a fixed ratio. The ratio is 80-20, T4 to T3. And for some people, if they take enough Armor Thyroid to get their T3 up to where it's okay, the amount of T4 is way too much. And they will just continue to make more and more and more reverse T3. But meanwhile, their TSH has gone down to almost 0. And they may feel better for a while, but they don't stay feeling better. And so not only do they not feel better, but they will frequently get hyperthyroid symptoms along with their not feeling better. And one of the hyperthyroid symptoms is heart failure. Rapid heartbeat, palpitations, and heart failure. So it's really dangerous to take too much thyroid medicine.
So, just to back up a little bit, because we've said a lot of T's, and for someone who doesn't live in the world of thyroid, right, it can get a little confusing. So we mentioned TSH, I think intermittently, but that is a thyroid stimulating hormone, and that's the hormone that kind of, I look at it as the whip. That's what kind of whips your thyroid into shape, right? So your TSH whips it into shape, and then your thyroid produces hormones, and those are the hormones Dr. Gibbs talked about. She talked about the free T4, which your body knocks off one iodine molecule and it becomes a T3, and that's what works and prevents you from moving around like a turtle. Okay, but sometimes when you have an autoimmune thyroid disease like Hashimoto's, and Dr. Gibbs, stop me at any time because you're the expert. I'm just trying to interpret my yeah. So if I'm off keel at any time, stop and correct. And so so free T the free T3 is basically the functional part of your thyroid. So your thyroid produces this free T4. You take off an iodine that should be taken off. You get a T3. T3 goes to the cells, and that's what kind of keeps you metabolically active, right?
Right,
If
absolutely.
you are low on thyroid, then everything turns sluggish, and you lose all the good stuff. You lose your hair, you lose your eyebrow, your skin gets thick, your tongue gets thick, you can't think as well, you sleep more, your periods are all over the place. Some people can't even get pregnant, on and on and on. Basically, everything is slows down, like what I am about to say. Okay, so and then the gut also slows down, so you're constipated too, in
Oh,
addition to everything else.
horribly.
Yeah.
Terrible, terrible,
So
horrible.
so
Doesn't
so
respond to fiber.
yeah. So then when you have an autoimmune thyroid disease, what that does is that your antibodies kind of attack your thyroid, right? So it produces this free T4. So something's really high, really low, really high, really low. And so when there's all that free T4 going around, your body is like confused. It's like, well, how much of it am I going to convert to T3, which is what it should do? And then some of it just knocks off the wrong iodine. And
Yeah,
then this abnormal T3 is really what it will sit on the receptor. It will sit like, oh, it's kind of a wannabe. I want to be T3, but it really can't do the job. So Dr.
yeah,
Gibbs' analogy, which I love, is the key fits your door because you got a new key because you lost your key. And now you try to turn it and you're like, oh, they didn't do it exactly. And if you keep messing with it, you're going to have to change your whole lock system, right? So the
right,
T3 that's produced by all this fluctuating um, free T4 is really not the T3 that is useful to you. So there's a way
right,
to measure, right? So even if your doctor says, hey, your TSH is fine, your free T4 is fine, go, your T3 is fine, they can look at your total T3 and the ratio to the reverse T3. And if that ratio is greater than 10,
it's all good.
okay,
If it's less than 10, if it's around 6 or 7, a lot of times people will not feel well. But here's the thing, I don't want to make it sound like Hashimoto's disease is the only problem that causes this
yeah,
abnormal
fluctuating.
elevated reverse T3. So there's several things that can do it, and stress is one. And stress can be a lot of different things. Stress can be over exercising.
Yeah,
Stress can be mental stress.
yeah,
Stress can be starving. And I will
yeah.
tell you, your body cannot tell the difference between I'm trying to lose weight and I'm starving to death.
And there's no food
If
in
you
town.
if you restrict calories,
Yeah,
or if you have select nutrients that are
yeah,
deficient in your diet,
yeah,
your body thinks that you're starving and it
yeah,
will shut your metabolism down. And this is exactly how it does it.
yeah,
It may not be the only thing that happens. The other thing that happens is you get insulin resistant, but that's a talk for another day.
yeah.
Um,
We may have to call you for that one.
I just I just gave that one live this week. It's fun. Um, but so, and then of course the mechanism, the reverse T3 is there to protect you. It's
Yeah,
there to protect you against too much thyroid medicine. So the other
yeah.
situation that causes a lot of times for people is taking levothyroxine, which is
Mm,
the synthetic the thyroid medicine that most people who don't have enough thyroid hormone are given. And
yeah,
I would say between 10 and 20% of people who are given levothyroxine have exactly this same reaction to it. And so they take the medicine and they feel worse. They don't feel
yeah,
better.
yeah,
And it's really very sad because I don't think there's enough time in, you know, you know, 27, I could work 27 hours a day and not take care of all the people that have that
But
problem.
you know that, but we still need you, and so I think we need people, doctors like you, in kind of two realms. One is to educate other doctors, because that wasn't in our medical school curriculum or even our residency.
No, it wasn't.
Yeah.
No,
So
it was not.
especially we need people like you to kind of inform, have classes for other doctors like us, so that we can get educated and actually know how to help our patients. Because we are trying to help our patients, we just don't have the knowledge, especially primary care docs. And then, how can people find you that do want to work with you?
Sure.
Seems like a lot of my patients will be needing your help, I'll tell you that.
Yeah. Okay. Well, thank you. So my website is my name. It's danagibbsmd.com. And the cool thing about my website is that I have tons of videos, tons and tons of educational videos about all these different topics that you can go and listen and get educated. And I really do try to keep it simple enough that people who don't have a medical background can understand. But if you do have a medical background and you want to learn how to do this stuff, I also have a physician's course that I proctor. Now, I'm not the teacher of this course, but I am the tech person that helps the doctor who is even farther out from medical training than I am, who taught me and who teaches this class. And it's not just about thyroid, it's about insulin resistance, it's about male and female hormones, it's about vitamin D, it's about so many things, because you really can't just learn about one hormone.
Yeah.
Once you get into it, you realize the water is really deep.
Yeah.
And you have to learn more and more and more.
And then I see also, so that class is for primary care doctors, anybody who wants to, nurse practitioners, anybody who wants to learn it. Anybody who wants to, that's good to know that it's open to professionals to really learn, because like you said, there's only one Dr. Dana Gibbs, right? So people who can really learn, come there, learn, and then go take care of patients. And then that's how I think we get people taken care of. So, okay.
So yeah, so we're going to start that live sessions again, I think April 15th, April 14th.
Okay, love it.
Something like that.
April 15th, docs and nurse practitioners. Let's find out what to do with people when their thyroid TSH number 3T4, but they still feel like heck. Okay.
Yes.
Well, Dr. Dana Gibbs, thank you so much. This was I learned a lot. Right? It's not like I need to come to your class. I learned a lot. I really appreciate you coming. So website, YouTube channel at Dana Gibbs MD 8190, and we're going to post it at the bottom of the page when we air this. Thank you so much for coming. I really appreciate your time.
No, this has been a real honor to come, and I'm a real big fan of Dr. Dada, I got to tell you.
Thank you so much.
All right.